I'd like to call up Tammy Warkentin to come up. She is a nurse practitioner in the neonatal intensive care unit. And she's here to discuss neonatal abstinence syndrome, as we heard in discussions earlier this morning. It's a condition that occurs in newborns that have been exposed to addictive, illegal, or prescription drugs while in the mother's womb.
Thanks for having me here today, and thanks for everyone who came. And I particularly like to thank my colleagues from work who are here to support me. Pat and Elaine are sitting at the back table there. They're RNs in the NICU. And Joya, you've already met. And Krista, who is a midwifery student who's in our unit for the month, and she's from Laurentian University. So thanks for coming, and feel free to stand up if you'd like to add something to my presentation, or tell me, no, that's not the way it is, or this is the way we do it in Windsor. I'm relatively new to their NICU, and they've really helped me establish my role there, and I'd just like to thank you for coming. So, neonatal abstinence syndrome, it is obviously becoming an increased burden in society and as well in our NICUs. 22 years ago when I started as a nurse practitioner, it was rare that we saw a baby with withdrawal in our NICU. That doesn't mean we didn't have a baby with withdrawal in our NICU, but we maybe didn't recognize it, weren't looking for it. So we've already talked about maternal use of drugs, so I'm going to skip this slide because most of this has already been presented. This is going to happen a little bit in my presentation because I don't want to repeat information for you. But specifically, the neonatal problem. We already know it's an identified problem in Canada and Ontario, and our highest use of prescription narcotics. We have the highest use in Canada as well as one of the highest in the world. And between 1991 and 2009, the number of prescriptions for oxycodone increased by 900% in Ontario. 280 Ontario physicians are authorized to prescribe methadone. There are 41 methadone clinics in Ontario and approximately 26,000 patients in methadone clinics. This increased use translates to increased intrauterine exposure for women who are pregnant, and then of course increasing neonatal abstinence syndrome. Increasing abstinence syndrome requires increased hospitalization, and our national hospital average stay for these babies is 15 days. It used to be 1 to 3 cases per 1,000 births from 2004, and in 2010 we now have 4.3 cases per 1,000 births, and that's in Ontario. In Ontario is the red line, so we actually exceed the national average. And in 2011, at least 1,057 infants born in Canada had NAS as their diagnosis, and that was an 18% increase from 2010. Those won't be exact numbers just because of the way diagnoses are coded, and I don't have a great knowledge of how diagnoses are coded. I've never worked in a coding department, but there are certain limitations in this data. And just on the bottom right there, the far column, beds per day utilized across Ontario, we can expect that anywhere across Ontario, 23 neonatal beds a day are occupied by infants experiencing abstinence syndrome. So that's a heavy burden on our NICUs, and it does, of course, affect retro transfers back from level 3 NICUs to level 2 NICUs if our beds are being filled up with babies with neonatal abstinence syndrome. The cost, this has already been presented, I believe, by Dr. Mundell. The estimated cost in Canada is approximately $40 billion per year. But determination of this is, of course, difficult for all the limitations already listed, such as self-report, lack of understanding of the consequences, and looking at studies in particular populations, which is then difficult to generalize. Management is complex. This has already been addressed. These moms often have coexisting morbidities such as infections, all the psychosocial factors that we're all aware of and have been presented at length today, socioeconomic factors, obstetrical complications, which Dr. Mundell has already spoke about, pain management issues, and the issues of polydrug use. Specific for infants is these infants can end up with low birth weight, which just means they're smaller than the average infant, IUGR, which is actually growth restriction in utero, and prematurity. And prematurity comes with many comorbidities, including hemorrhages in the brain, which we call IVH for intraventricular hemorrhage, respiratory distress, lung disease, moving into problems with chronic lungs, and then problems with chronic lung infections when these children get older, infections in the NICU that can increase their mortality, problems with their eyes, retinopathy of prematurity could possibly lead to blindness. So there's lots of morbidities that come with being premature if you're born premature because of drug exposure. The challenge, we know we play a key role in healthcare and helping these women, yet we have an identified lack of knowledge and training regarding the effects of and treatments for substance use during pregnancy. We're also challenged with respect to how to best provide care to this mother-infant dyad. I'm certainly not an expert in the care with neonatal abstinence syndrome. Because of our increased exposure, I've had to do a lot of reading and I've attended a lot of conferences, but I don't consider myself an expert. I think we all work hard to provide the best care we can and to increase our knowledge. For this reason of our lack of knowledge, the PCMCH, that's the Provincial Council for Maternal Child Health, has developed a neonatal abstinence syndrome work group, and they put together recommendations for harm reduction and optimal management of neonatal abstinence syndrome. They've described the scope of the issue. They've looked at resources and practices regarding NAS in Ontario. They've recommended strategies for us to formalize linkages in the community, recommend clinical guidelines for the management of NAS, and they're nicely outlined for us for specific management within the neonatal intensive care unit. And we've already been through the maternal recommendations today with Dr. Mundell, so I'm going to pass this over. And just a little bit more about methadone. Of course, within those guidelines is methadone maintenance is a standard of care for pregnant women with opioid dependence. I think most of that has already been addressed. Benefits of methadone is that when these moms are taking methadone, the exact potency is known. This is the cost I managed to find in the literature. These moms spend less time on drug seeking or behavior to support this habit. Caution, it can block the effects of other opioid drugs, so risk of overdose can be an issue, and they will still have withdrawal if they miss a dose. And I'm not all the expert on methadone with moms. And these moms need consultation with an addiction medicine specialist, as has already been presented. And there's really inconsistent results with the severity of the withdrawal and the dose that the mother is receiving. Buprenorphine has already been discussed. That's an alternative to methadone. Now, again, my understanding was the only preparation in Canada is Suboxone, but there's some safety on this with pregnancy because there's naloxone in it, and Subutex is actually the drug we want to use in... They
will supply Subutex.
Okay. Okay, so Subutex is available. Okay. We really don't see very many babies on buprenorphine in our NICU. I think I've seen one in the last year and a half when I've been on service. So looking at methadone versus buprenorphine for these for women, there was a study done in 2010 looking at 175 pregnant women. It was an RCT, and they were treated with methadone or buprenorphine. And the group that was treated with Suboxone is a lot easier to say, so I'm just going to say Suboxone. They had significantly, these infants needed significantly less morphine for the treatment of their abstinence syndrome. They had a significantly shorter hospital stay. But there was no difference really in the number requiring NAS treatment, the peak scores, head circumference, or any other neonatal outcomes. And it was felt because women taking Suboxone or Subutex were more likely to discontinue treatment, that it wasn't as optimal as methadone, just for the sake of being in a program. Specifically, neonatal abstinence syndrome is a multi-system disorder frequently involving the central nervous system, so our brain, our nervous system, the gastrointestinal system, the autonomic nervous system, and our breathing system. Manifestations depend on various factors. The drug the mom is using, its dose, frequency of use, the infant's own metabolism, and excretion of the active compounds in the drug. It also depends on the infant's last exposure, the timing of the infant's last exposure, and the mother's metabolism and clearance. The longer the half-life, the later the onset of withdrawal. Half-life of a drug just means how long it takes to get to a certain concentration in the blood and how long the drug takes to exit the system. And a longer half-life is associated with a decreased likelihood of NAS. Opiates produce the most dramatic effects on both the mom and the baby. Between 48 and 94% of neonates exposed to opiates will show signs of withdrawal, and they usually manifest at 1 to 7 days of age, usually within 72 hours. A small portion of these babies, or smaller portion of these babies, will require drug therapy to get through this withdrawal. And this onset of withdrawal, as I was already said, is dependent on the half-life. Heroin symptoms usually begin within 24 hours. Methadone, usually within 48 to 72 hours, but can be up to 4 weeks of age. Withdrawal from methadone is more severe than withdrawal from heroin. And the length of treatment has been reported anywhere between 7 and 49 days if they need morphine therapy. And I've certainly seen both ends of the spectrum. With methadone, again, the withdrawal does not necessarily correlate with the dose of the methadone. This is certainly true. There are some reports to say that if a mom's dose is less than 100 milligrams and she's breastfeeding, there's a less likely incidence that the baby will require drug therapy. It's traditionally believed that it's the drugs in the breast milk that help, but the more I read and the more I talk to experts that manage neonatal abstinence syndrome, they really feel that it may just be the breastfeeding that has the most effect, not the drugs in the milk, because really the amount of methadone that's in the milk is really a very, very small dose. That next video was just a picture of a crying, screaming baby to show you how these babies cry. And their cry is piercing and shrilling, and if anybody's heard it, it's a different cry. It's hard to, when you're skilled at assessing these babies, you'll hear that cry and you'll suspect that it is neonatal abstinence syndrome. Anyway, the newborn recommendations from the PCMCH include testing, monitoring, scoring these babies, and treatment. This is just an algorithm they provide us. You won't be able to see it, so I'm just going to move on and describe it in detail. For toxicology testing, Dr. Mundell already kind of spoke about that. For moms, you have to have informed consent. For babies, it's a different issue. If we get a baby in the NICU and we're suspecting withdrawal, we can send a urine. But I think, it's my opinion, ethical practice, we should go tell the mom we're sending it. We do have the authority to send it before we go talk to her. But it is good practice because it sets up, if we don't go talk to that mom, obviously it sets up a whole picture of mistrust with that family, and it sets your tone from there on in the NICU. And we're there to work with these families, so we want to provide optimal communication. Here in meconium samples, we only send on the request of CAS because obviously because of the cost. I believe a meconium sample costs around $400. I don't know what a hair sample costs. Does anybody know exactly what they cost? No? Okay. And really, a hair and meconium sample is really not helpful to us at all because by the time those test results come back, most of those infants are discharged from hospital. We get a result and it's not helpful for us at all. So urine testing is what we send. And the PCMCH has asked the Ontario Health or OHA to come up with consensus regarding urine testing and what the legalities are around that. I've asked that in many meetings with physicians and co-workers, and everybody has a different feeling on, and it is kind of different in how they practice in that area. We're not really consistent. So limitations of drug toxicology there are ways to avoid detection for adults. With respect to the baby, alcohol is very hard to detect because it has such a short half-life. And the amount of drug, for example, in a hair sample correlates with the degree of drug use, but is not a diagnosis of addiction. We have to remember that. And that a false positive can have serious legal and emotional consequences. Even a false diagnosis can have these consequences for a family. And there are some drugs that can produce false positives, and I don't remember those off the top of my head, but that can happen. So urine testing is our most common test. Most drugs are detected only within hours to several days after consumption. It should be done on the baby's first urine sample, but often it isn't because we maybe don't pick up the signs right away if we don't have any indication from mom. If the urine is positive, we don't send a meconium unless we want to test for alcohol. Then you send a meconium to test for the fatty acid ethyl esters that would be in the meconium. And if the urine's negative, you could test the meconium for the above substances and alcohol if you still were thinking there might be some issues. And of course, as Joy said, all positive tests that are of illicit substances are reported to Child Protective Services. But before we do that, we look at the urine sample and look at the mom's drug history, because oftentimes mom's urines will test positive for opiates because they've gotten pain medication during labor and delivery, or they're on some anti-anxiety, antipsychotic medications that are prescribed. So these are all the drugs that are in our urine drug screen, and I won't read them all off, but there they are. So cocaine can be in the urine for 2 to 3 days if there's heavy use. Marijuana, 13 days or greater, up to 30. I've even read up to 90 days if it's very heavy use. Methadone, 3 days. Morphine, 48 hours. Benzodiazepines, 3 days. And this slide's just showing the same thing. Meconium is really the best method for detecting drug exposure, and it should be done on the baby's first sample. That's an example of what the baby's first diaper looks like. It looks like a black tarry substance. And depositions of the drugs in meconium theoretically begins around 12 to 13 weeks gestation, so it picks up a very large window of drug use. Hair begins to grow on a baby in the 3rd trimester of pregnancy, and it's shed around 2 to 3 months after birth, so you have a while. The benefit of this sample is you have a while to collect it if you expect anything much later on. And sometimes it may be done at the discretion of a physician if you've missed your urine and meconium testing. Assessing known or suspected cases of NICS, what is NAS, what is acceptable or is suggested we use is a modified Finnegan scoring tool, which I'll show you. It's to provide a quantifiable, objective means of monitoring severity of neonatal abstinence syndrome in response to treatment. It's not designed to monitor withdrawal from substances other than opiates, although it is used for substances other than opiates as well, because oftentimes we have polydrug use, or people just don't know and we have nothing else to use and we pull it out and realize it's not all that helpful. And in order to use this, you need to use it frequently, and you need to be able to provide consistent results between staff member to staff member, which is sometimes difficult. In the NICU, it's very easy to score babies because babies are within our view throughout the whole 24-hour period. There's always a nurse close to the bedside. On the mother-baby floor, you know, the babies are with the moms. There may not be a nurse in the room all the time. You have to rely on the mother's report, and that can be very accurate. I'm not saying that couldn't be accurate, but it's just you're not with that baby as in close proximity, so it's much harder to score. Oftentimes babies will be admitted to the NICU with a high NAS score, and we actually score the baby, and our score is usually, it's rare that it's higher, it's usually lower. So the reliability of this tool is supposed to be about 82% accuracy between trained nursing staff. And the intent of the tool is to rate the severity of the withdrawal for titrating drug therapy. That's really the intent of it. It's not really for diagnosing, but we do use it for diagnosing as well. Ron Abramson, who is the coordinator of the clinic in Vancouver, felt this tool was far too subjective, and he took it and he revamped it to take all the subjective items out of it. And one of his comments was, if you look at the tool, if you look at the name on the top of the tool, it's called neonatal abstinence syndrome scoring. So as soon as we put this form in a chart, the baby essentially has a diagnosis of NAS, even though it may not be written in the chart as a diagnosis of NAS at that point. It primes the observer to score the baby for neonatal abstinence syndrome. So I would tend to agree with that. I think we become biased sometimes when we have this form on the chart, although it's the best we have right now. And if you look through it, you're not going to be able to see this from, everybody's going to be able to see this if you're sitting at the back of the room, but it goes through all the central nervous system disturbances, the respiratory issues, and the gastrointestinal issues. So I've showed you some of the neurological system disturbances they can have with those videos. Other things are they can sneeze, they can have like a modelly skin tone, they can have a fast breathing rate. They tend to suck on their fists a lot. It's like a panicking suck. They try to stick their whole fist in their mouth and they just suck ravenously. They can be sweaty, they can have vomiting, diarrhea, regurgitations of their feeds, watery stools, which then leads to diaper rash. They can have severe diaper rash, fever. And all these symptoms have a particular score. You can score the baby and then you add the total up at the bottom. This is the observation sheet that Ron Abrams uses in Vancouver. You can see it's far less subjective. It doesn't have neonatal abstinence syndrome written on the top. It's just a neonatal observation sheet. It doesn't really have a score. I think the score is helpful, but I do like it that it doesn't say neonatal abstinence syndrome on the top. So when we take this tool, any baby that's exposed to methadone in utero has to come into the NICU for 120 hours of monitoring, so 5 days, because at that point, after 5 days, you're past the risk of severe withdrawal for the most part. So they come in for 5 days, they have to stay for 5 days, and we score them for those 5 days. Any baby that has other narcotic exposure or any other drug exposure, it's 72 hours. Again, that form is only for narcotic exposure. If I have time at the end of this presentation, I'll go through a few other drugs and what we see with those babies. If we have an average of 3 scores that are greater than 8, or an average of 2 scores that are greater than 12, that's when we start considering giving these babies drug therapy with morphine. Any baby who has vomiting, diarrhea, is not gaining weight, not tolerating feeds, they're an automatic candidate for drug treatment if supportive measures are not working. And any baby who has any type of seizures is an automatic candidate for morphine therapy. So it's not just the score, but it's those other things as well. We should support room in if the infant is in the NICU. We try to do our best to support rooming in. We don't really have the geographical facilities to keep these moms and babies together 24 hours a day necessarily, because we don't have enough rooms, but we do attempt to keep them together as much as possible. It would be really nice if we had extra floor space, extra rooms, so that it could be one baby, one mom in their own room. Preterm infants are a particular issue. Premature infants are very hard to assess for neonatal abstinence syndrome. They don't tend to score the same way as term infants. Often the signs and symptoms of all neonatal problems with prematurity are the same signs and symptoms of withdrawal, so they're very difficult to score. I mean, we all know we miss abstinence in a lot of babies if we don't know a maternal history because we just can't pick it up in the preterm infant. So I've already touched a little bit on models of care, but the traditional models of care are supportive care, minimizing decrease in sensory stimulation, so keeping these babies in quiet environments, small frequent feeds, giving narcotics. And traditionally, we've years ago separated these mothers from these babies for the careful purposeful observation. And this is no longer the recommended standard of care, of course, because we know that it's not ideal to separate moms and babies. So emerging models of care, keeping moms and babies together. And here in Windsor, we're somewhere in between that just because of the geographical issues within our NICU that I spoke about. There is an example of a clinic in Vancouver called the First Square Clinic. Is anybody familiar with that clinic? Has anyone heard Dr. Ron Abraham speak? Anyway, it's a clinic where they keep moms and babies together for the entire hospital stay. And what they found is these babies actually needed less treatment. They were discharged sooner, and they are also more likely to stay in a mother's custody if they did this rooming and care. If you ever have a chance to hear him speak, he's a great speaker, and just to hear that presentation is so uplifting to hear the outcomes that they have. So just before we get into drug therapy, a little about non-pharmacological interventions. Swaddling is huge for these babies. Like the baby on the right, they like to be swaddled tight. Breastfeeding is the best for these babies if mom's not using illicit substances. And if they are, they should pump and dump. We encourage moms to to pump their milk, to keep their volume up, and dump if they're thinking they can get off their drugs, because then they can resume their breastfeeding when the drugs are out of their system. Environmental modification, so decreased noise, gentle handling. Kangaroo care is basically like the picture on the bottom, baby on mom's chest, skin to skin. Kangaroo care is something that works phenomenally for all babies, even our most premature babies. It's the most calming thing you can do with the baby. If we had enough resources in our NICU, we'd probably like to see all our babies doing this most of the day, even if they're on ventilators, even if they've got lines in, even if, you know, it doesn't matter. Any baby can kangaroo for the most part unless they're severely critically ill. Some NICUs manage to achieve this most of the day. In fact, some NICUs have the mom's bed right beside the baby's bed for the duration of the baby's stay. So that would be ideal. So just a little bit about drug therapy. If we get to where we need to provide the baby morphine, the baby needs to be on basically a heart and breathing monitor, because morphine can decrease breathing in a baby. So at least for the first 4 days, the baby needs to be on a monitor. Once you're on a stable dose and you're weaning, the monitor can come off if you so choose to take it off. So again, if our average of 3 consecutive scores on that scoring sheet is greater than 8, or 2 consecutive scores greater than 12, we consider drugs, or if there's any dehydration, vomiting, diarrhea, or seizure activity. Other drugs we sometimes use are phenobarb or clonidine. I won't get into those, we rarely use those. And discharge home on morphine has not been recommended, only in ideal situations. However, it's becoming a reality because we can't keep these babies in the NICU. We just don't have the bed space. And we know these moms can care for these babies at home and can safely give morphine with the appropriate supports in place. In our NICU, we usually at least have 1 baby in our unit who's withdrawing from a substance. In the past year, the highest number we've had at one time has probably been between 4 and 5 babies. That doesn't mean that doesn't translate to as many numbers as you think it would, but there's always, would you agree with me at the back table, there's usually a baby, and it's rare there's a day that we don't have a baby in there with withdrawal. So. Just a little bit about morphine weaning. Usually we keep the baby on a stable dose and we start it for a few days, and then we can wean every few days really slowly if the baby's tolerating it. criteria for a baby to go home on morphine is that obviously they have to go home. Some of these are obvious, but stable and supportive home environment, satisfactory psychosocial support, no identified risk for lack of follow-up. These babies are actually followed by our neonatologists if they're on morphine, so they'll see them weekly following discharge. They will also see them pre-delivery depending on what physician or obstetrician is managing this mom before delivery. They'll make a referral. Our neonatologist will see this mom. Joya will as well. They will tell them what to expect when they come into our NICU. Sometimes I'll meet with them just in passing so they have another familiar face when they come to the NICU. But importantly too, for discharge, they need following. They need a clear identified plan for weaning. So they should be on a weaning dose when they go home. And the parents need to be comfortable looking for the symptoms of abstinence, and they need to know when to contact a physician. And post-discharge follow-up as appropriate, of course. Other post-discharge follow-up. And those babies are closely monitored for growth, behavioral characteristics, and motor ability. Just a little about breastfeeding. In the NICU, we are the ultimate advocates for breastfeeding. HIV is an absolute contraindication to breastfeeding in North America, not in all places in the world because of the safety of water and formula preparation, but in North America, HIV is a contraindication to breastfeeding. Hepatitis C is the mom's choice. Alcohol is not a good thing with breastfeeding. Alcohol, if whatever a mom drinks, that's basically the amount, what's ever in her blood, that's the amount the baby's getting in breast milk. So any mom who plans to take a drink should pump off her milk, dump it, and resume breastfeeding in a designated amount of time. And there are charts that can be pulled off the Mother Risk website for mothers who intend to have an occasional drink. We don't recommend it, but we have to give them the appropriate knowledge if they're going to drink because they need to make informed decisions. And again, abstinence is what we would encourage. As far as opiates go in breast milk, they're only in breast milk in small amounts, and they're really unlikely to be of any significance as far as we know. The only one we have an issue with is codeine. So codeine has to be used with caution because without getting too biochemical, and I can't remember the name of all these substances, but some people rapidly metabolize codeine and it can be a huge problem, and then they end up with very high levels in their system. And this can happen with babies. There have been case reports where babies have died of SIDS, and it's been codeine overdose. So any moms who are prescribed codeine post-delivery, there's a certain period, probably 72 hours after delivery, where they need to change to something else if they're breastfeeding because of that potential risk. It's small, but we don't know who is a rapid metabolizer and who is not. If you are interested in learning about the different effects of drugs in pregnancy and breastfeeding, this is an excellent resource. It comes from the Mother Risk website. Mother Risk is a division of the Hospital for Sick Children in Toronto under the leadership of Dr. Gideon Corin, and many drugs listed in there, an excellent resource. Just a little bit about teaching parents. We need to tell parents that symptoms can persist for 2 to 6 months. Not necessarily a severe withdrawal, but still abnormal symptoms that are difficult to monitor. They may be more irritable, less cuddly, tremulous, have increased tone. These babies may be less responsive to visual stimulation. They don't necessarily like eye contact. That can be an issue for some of these babies. They'd rather look at you put them over their shoulder and look at a blank wall. They're less likely to maintain quiet, alert states. They have, for the most part, they have poor feeding habits. They regurgitate a lot. They have vigorous sucking. They sometimes cannot coordinate a suck, a swallow together. So, we have to work with them to get their feeds into them. They can have loose stools, which can, lead to dehydration or diaper dermatitis, which is diaper rash. They can be easily disturbed by sounds that would not bother you and I. They can be sweaty, they can have a high-pitched cry, and they can be not easily consoled. The biggest thing is they cry a lot, and to deal with the crying can be quite cumbersome. So discharge teaching needs to happen with all those aspects. And generally we like our moms to stay in the NICU overnight, at least one night before they go home, in our care by parent rooms. So the mom provides the total care for the baby and shows us that she can handle the baby and is also able to ask for support should she need it. And I'd like to suggest that we would like to continue to offer this to foster parents in addition to biological parents. And sometimes that's difficult because of time constraints. You know, if we have a foster mom coming in and really wants to take the baby home that day, and it depends on their experience with babies with abstinence, but we really encourage that they try to stay one night. We also encourage that the homes they're going to are able to provide the environment that's necessary for these babies. And I don't know, Joy, if you want to add anything to that? Just the issue with getting foster families in time to do this teaching and stay overnight. And
I don't want misunderstanding when you say overnight, one night. Usually, like the foster parents, like the parents coming in on a regular basis.
Yeah, in addition.
The baby before the discharge, because there is behaviors that cues that the baby will give, feeding and comforting, that isn't done just on the day of discharge. It's a gradual process. So we like them coming in regularly.
We have all our families watch the Period of Purple Crying video, and there'll be a lot of people in the room familiar with this video. It's just a video explaining newborn crying and what's normal, what's not. Of course, these babies are going to be abnormal, but it also explains the risks of shaking a baby and what can happen neurologically to a baby if you shake a baby, meaning severe neurological injury. It's really important to teach these parents that they also need to take care of themselves, that if they find that they're overwhelmed, they need to have the support so they can step out for a bit and take a break from this so we don't have a risk of shaken baby syndrome. Administration of medications, we spend a lot of time teaching these parents, if the baby goes home on morphine, how to drop the morphine, how to give the morphine, what signs to watch for that would be a side effect of morphine, such as respiratory depression. Unlikely to happen because they're on a weaning dose when they go home, but they still need that information because it is a potential. And this is an excellent resource that I found that I've read through that I really like. It's from the Vancouver coastal region. It's called Baby Steps. Many of you may be familiar with this resource. It's just a nice booklet for parents regarding baby care and specific issues with withdrawal in this book. It's a really, really nice publication. You can just print it off online. Just some risks for these babies. Risk of sudden infant death syndrome compared to any other babies. It's 3 to 7-fold higher if they're exposed to methadone, and 2.3 times higher if they're exposed to cocaine. The death is rarely associated from withdrawal alone, but occurs as a consequence of other factors in a risk of drug use in pregnancy, with prematurity, infections, and severe perinatal asphyxia if there's a severe event at delivery from, let's say, a perfusion issue from a cocaine overdose. And as far as neurological outcome goes in general, really, there's evidence that the social determinants of health might impact fetal development and infant development as much as the drug exposure. These children generally do well if their mothers don't use other substances and if they're raised in a supportive environment. Some adverse effects that are noted in some of the research are behavioral disturbances, brief attention spans, temper outbursts, learning disabilities, and delayed speech and developmental delay. There's many problems with these studies, though. They're small studies. You can imagine trying to get these families back for follow-up. You have a lot of dropouts in your numbers for these studies. And all these studies use different comparators. Some compared opiate versus non-opiate exposed babies. Some compared babies who needed morphine therapy versus babies who didn't need treatment. Others compared babies in foster homes versus in their biological homes. So you can't really compare the results of the studies. These babies obviously require close follow-up, and we really do need further studies to evaluate the impact of exposure. Most importantly, the importance of care partners. We need to be really sensitive to these families and their infants. They require a really unique skill set to take care of these babies. It's not everybody's expertise, even though it's the expectation that you care for these babies. So it's really hard for some staff members to get past why a mother would use substances in pregnancy. Why would she do this to her baby? You know, we keep having, you know, we have to educate staff about psychosocial issues and what contributes to a history of substance use. Most of these moms and everyone, I mean, you are far more experts than I am, most of you in the room, on the psychosocial issues, but many of these moms, of course, have experienced things that we can never even understand. And, you know, the question often is, why would this mom have another baby? I mean, we have that discussion all the time. Well, you know, we can't really conceptualize that. And, you know, we need to start understanding these things, but really we're not going to fix those problems in the short times those babies are in the hospital. We just need to be there to provide the most supportive care that this mother-infant dyad requires, and to have that mother or that family know we're there for them, and that we're not going to judge them. We're going to give them the best experience they have with their baby. For some of these moms, that time with their baby is maybe the only good experience they're going to have in the next future, in the future. So, you know, we really need to be compassionate and not think that we can change things. We can give them informed information, give them our best advice, but we can't necessarily change things. And we really need to remember that a history of substance use is not necessarily incompatible with an ability to parent. And we'd better get good at treating this and taking care of these families, because we're just going to be doing more and more of it when we look at our statistics. So that's all I have to say. I have a little bit on specific drugs. I have no idea what time it is, so if I have time, I'll do it. If not, I'll leave it. 5 minutes? So I can do that quickly, or I can field questions. You're going to have to decide what you like.
Is there any questions?
Go ahead. Okay. So just a little bit about cocaine. Cocaine obviously is not a good thing to use when you're pregnant. It can cause massive fluctuations in blood flow. So it can cause fetal growth retardation. It can cause hypoxia, which is basically not enough oxygen to the fetus, which then can have devastating effects. Without reading all those, anything that gets, any part of your body that gets circulation can be impacted with a dose of cocaine, because it can abruptly, as I said, halt your circulation or decrease your circulation or cut it right off. So you can get babies born with limb defects, cardiac or heart defects, anomalies of any part of their body, severe asphyxia at birth, meaning that the oxygen's cut off, so they can end up with severe neurological issues or death. It doesn't produce an abstinence syndrome. It more produces a permanent abnormal neurological behavior. Alcohol, fetal alcohol spectrum disorder is a constellation of 3 findings: growth retardation, symmetric, meaning the head growth and the length in the baby, facial dysmorphism, and severe neurological dysfunction. So alcohol and cocaine are obviously not good in pregnancy, we know that. Cocaine is definitely contraindicated for breastfeeding. Alcohol is also contraindicated for breastfeeding, but with alcohol, because the half-life is Well, with both of these, if you're abstinent within a period of time, you can breastfeed, but you need to pump and dump if mom's breastfeeding until that's out of your system. Antidepressants is a huge issue for us. I'm always, in a lot of antenatal charts, we say there are a lot of moms on antidepressants during pregnancy. It can cause, specific ones can cause problems for babies, and what we'll see is these babies can have breathing distress, seizures, problems with temperature, feeding difficulties, vomiting, problems with blood sugar. Generally, these symptoms disappear within the first few days of life, but they are kind of a diagnostic dilemma because these are all the symptoms of neonatal infection, which is often a common initial diagnosis, respiratory distress, all these things. So sometimes it's really difficult to differentiate what the diagnosis is here. Sometimes it's only when we go back and ask the questions do we realize, oh, maybe we were dealing with SSRI withdrawal and not with infection. So it's really important that we know what drugs moms are on. Amphetamines basically are stimulants, and they're toxic to the fetal brain. Can cause bleeding in the brain, infarctions, meaning no circulation, and then areas in the brain can die off if they haven't gotten circulation, proper circulation. And then permanent neurological effects can occur. And sometimes these effects aren't shown until the child is much older. Marijuana is a huge issue because marijuana use is quite prevalent, and in the NICU we often get a lot of moms giving self-reports that they use marijuana, and I don't know if it's because they're so worried about their baby in the NICU that they're predisposed to admit to more, because I've talked to other practitioners in other areas and they say, well, we don't hear as much of that. So I'm thinking that we get a lot more self-report just because the mothers are so worried about their babies, they'll do anything to help get out of what crisis they're in with the babies. But we really don't know what the long-term effects of marijuana are. It is contraindicated for breastfeeding according to the American Pediatrics. But when you look on the Mother Risk website at the Hospital for Sick Children in Toronto, the comment is made that if a mom is taking marijuana and breastfeeding, then you really need to weigh the benefits of breastfeeding over not breastfeeding. That's a very open statement. I will tell you that all physicians practice, when I ask the question, all physicians practice differently on this situation. Most are aware of the guidelines, but we're in a dilemma because the use is quite prevalent. The only real studies that show anything are there are some studies that show some decreased motor development at 1 year of age. But I think the best recommendation, if we all sit around the table, is that we really don't recommend it, but we have to give the mom an informed choice. And when we give her an informed choice, we really don't have a lot to tell her because there's not a lot of information out there. So I guess I don't have a straightforward answer on that, except that it's becoming a real dilemma. I think that's everything. Thanks for your attention.